just a few couple of questions that we thought we could all ask all of you all to participate in. The first question on Kawasaki. Where was Kawasaki disease identified? There's a option of live poll on your screen. You all can click on it and you all can participate in the poll. So the first question being, where was Kawasaki disease identified? China, Taiwan, South Korea, or Japan? In case the doctors have answered, we can go ahead for the next question.
Yes.
What is the acronym to describe the clinical features of Kawasaki disease? CPAP, SOB, crash and burn, or ARF?
Sound.
The next question, cardiac involvement in Kawasaki disease may manifest as myocarditis, pericardial effusion, coronary aneurysms, or all of the above. Next question, please. Echocardiography is indicated in Kawasaki disease at the onset and then weekly thereafter, or at diagnosis followed by 2 weeks and then 6 weeks after onset, or at diagnosis 2 months and then 6 months after onset, or only if there are ECG changes. Intravenous immunoglobulin IVIG is given as follows: either 400 mg per kg over 10 to 12 hours, or 2 grams per kg over 10 to 12 hours, or 1 gram per kg per day for 5 days, or 400 mg per kg per day for 10 days. Thank you, doctors who took part in the live poll. Kalpesh, can we have the answers? Dr. Paul, this is the right answer is Japan.
Yeah.
And most of you seem to have got it.
Yeah, definitely.
Yes, sir.
Answer for the second.
Is again option 3. Everyone, most of them have seemed to have got it right.
Mm-hmm.
Here again, there's a bit of mixed reaction, but again, the right answer is option 4, all of the above.
Yeah, yeah.
Here, there's a clear cut, at least slightly, but much more clarity in terms of the answers. It is option 2.
Yeah.
And the last one is as well almost right. The answer is 2 grams of kg per kg over 10 to 12 hours.
So we have a group of doctors who are already kg oriented.
Yes, sir. Looks like.
We have a very active audience.
Yes, ma'am, we do. Sir, I'll before we start this session officially, we wanted to sort of have an 1 minute of silence in honor of Dr. Tomisaku Kawasaki. Kalpesh. Yes. Like I mentioned earlier, before we wanted to start this webinar, we wanted everyone to we request everyone to hold a minute of silence in honor of Dr. Tomisaku Kawasaki. Dr. Kawasaki was a Japanese pediatrician who first noticed the Kawasaki disease in the 1960s as a junior doctor. He died at the age of 95 due to natural causes in June 2020. This enigmatic smile of his, we are sure, will continue to inspire several generations of pediatricians in coming years. A minute of silence, please. Kawasaki's blessings, we initiate the program. I now hand over the session to Mr. Anand Barne. He's a general manager for marketing from PlasmaGen BioSciences, to officially welcome this esteemed panel of doctors.
Good evening, doctors. On behalf of PlasmaGen BioSciences, I cordially welcome you for this webinar. PlasmaGen BioSciences is a proud Indian biopharmaceutical protein therapy arena since its inception of 2010. We as the organizations are actively working towards bridging the gap of demand and supply of plasma products in India, and coincidentally also bridging the knowledge gap by bringing the several young and budding doctors with eminent doctors like you on a single platform. For the last 10 years, PlasmaGen BioSciences has been active on the ground and create awareness about several immunodeficiency diseases such as Kawasaki and PID. We plan to continue spreading awareness about these conditions with more such knowledge-based sessions, and we'll keep you updated about it very soon. Now about this webinar, I'm sure at the end of the session, there will be a lot of so beautifully put together by Dr. Priyankar Paul and team. Over to them now. Thanks.
Sadly, we'd like a proper, we'd want the Dr. Priyankar Paul has been so kind enough to help us out with everything. Yes, Abhinandan, can you welcome Dr. Priyankar Paul, because you worked with him closely for the last 7 years or so?
Definitely. Thank you, Anna. So first of all, for laying down this roadmap for PlasmaGen to create more awareness around Kawasaki and other immunodeficiency affecting these children. And I was personally, to be very honest, I was personally very fortunate enough to have met one such visionary around 7 years back itself in Kolkata, Dr. Priyankar Paul. Dr. Priyankar Paul is tirelessly working in order to create more awareness regarding this Kawasaki. But although once you meet him, he'll never forget to greet you with a smile. And with close to around 50 research papers across various Indian and international journals, I doubt if there is anyone from the audience who would not, but still in case who might not be aware, Dr. Priyankar Paul is the professor of HOD of Pediatrics and Pediatric Rheumatologist in the Institute of Childhood, Kolkata. In addition, he is the secretary of Indian Society of Kawasaki Disease for India. So thank you, Dr. Paul, for guiding us for this program, and it's all over to you. Please take us to the section. Thank you, sir.
So a big thanks to PlasmaGen for allowing us to participate in this program, inviting us for this program, and again raising consciousness and awareness about this mysterious disease. Even after so many years, Kawasaki remains underdiagnosed, so to say the least. And today evening, we will try to look at Kawasaki disease itself, as well as the presently described COVID-associated Kawasaki disease like hyper-inflammatory syndrome. So shall I start the presentations?
Please.
Yes, sir. So for the first initial part of the talk, we will be on diagnosing Kawasaki disease. In 1967,
Sorry, sir. We can't see your slide, sir.
you can't see my slide? Just one moment. Is it okay now?
Yes, sir.
Yeah, it's okay. No, it's okay.
Over to you, sir.
Okay, fine. So, in 1967, an original article entitled "Infantile Acute Febrile Mucocutaneous Lymph Node Syndrome: Clinical Observations of 50 Cases" was published by a Japanese clinician in the Journal of Allergy. So it was a Japanese publication with English abstracts. So this was based on 7 years of observation of 50 cases, which he found to be something new, something not what he had seen before or read in any textbooks. And this laid the foundation of the so-called Kawasaki disease. In 2002, this original article was translated into English. Jane Burns, who happens to be one of the most prolific publishers and one of the most knowledgeable persons globally on the subject, and who happened to be also one of the translators, commented, in his exhaustive detailing of every observable aspect of the disease, Kawasaki was part Sherlock Holmes and part Charles Dickens, with his sense of mystery and his vivid descriptions of the clinical features of these patients. So you can understand the detailing that he had described in his original article. So, diagnosis, this is the American guidelines that came out in 2017. So a child with fever for 5 days, of course, again, that 5 days is presently arbitrary, because even an astute clinician with the classical findings can diagnose Kawasaki with a fever of 3 to 4 days. And the classic findings are erythema and cracking of the lips, strawberry tongue, and or erythema of the oral and pharyngeal mucosa. Bilateral bulbar conjunctival injection without exudation. So it's a dry conjunctivitis. A rash. It can be of any form except a bullous lesion or a vesicular lesion. Erythema and edema of the hands and feet in the acute phase, and or periungual discomation in the subacute phase, and finally a cervical lymphadenopathy, which is usually unilateral. So since it's a visual presentation, so we will have a look at some of the pictures. So I think pediatricians can really make a diagnosis very astutely in these patients. A young child presenting with the non-purulent bulbar conjunctivitis, the mucositis, the edema of the hands and feet, and this rash. You can have almost any form of rash except, as we said, a vesicular rash or a pustular rash. So it can be of any form. Look at these rashes, almost erythema forming, erythroderma-like. So you can have a variety of rashes in AD. So these are all rashes in patients of Kawasaki disease. A certain thing which has not been very acutely described is the perineal desquamation. So we have the periungual classical desquamation, but preceding the periungual desquamation, you have the perineal desquamation. So one has to look for this perineal desquamation and cervical lymphadenopathy. So occasionally it has been described the cervical lymphadenopathy can mimic a suppurative lymphadenitis. You can see the redness and the swelling and the tenderness in these patients. And this is something that has been lately described. So this is what you call a retropharyngeal phlegmon. So you can see the edema over here on the MRI plate in the retropharyngeal space. So this is another presentation of Kawasaki disease with a retropharyngeal phlegmon. A very interesting finding, and this is almost pathognomic of the disease, is the reactivation of the BCG scar, present in around 10 to 15% of the patients. So if you have a reactivation, it's almost pathognomic of the diagnosis of Kawasaki disease. This is an interesting finding that we had described. Color changes in the nails. So there is a orange-brown coloration of the nails that we first described as a case series in Pediatric in Rheumatology International in 2011, and subsequently it has been described globally, and this is the final publication that we had just a month back, 10 years since the original publication, so the Indian Journal of Pediatric Dermatology. So this is presented almost 60 to 65% of the patients, and this is something which appears in the acute phase and stays for a substantial amount of time. So please look at the nails. You can come across this finding. Now, classical Kawasaki, I think most of the pediatricians can now almost diagnose with certainty a patient with classical Kawasaki. But occasionally, in almost 20 to 30% of the patients, you will find something which is, you don't have the classical features, that is known as the incomplete Kawasaki disease. So these are the American guidelines again. So children with fever or 2 or 3 compatible clinical criteria. So you do not have all the 5 features, you have some features, or infants with fever for equal 7 days without other explanation. So this is a very, very important category. Infant with a pyrexia of unknown onset without any other features can again be a Kawasaki disease. So you have to look the laboratory tests at that time. So a raised CRP, a raised ESR, and then some of the laboratory findings that anemia, unexplained thrombocytosis. So this is one of the very important things that you need to look whenever you are looking at a patient with unexplained fever. A platelet count is often ignored. Sometimes a lot of labs, they do not report the platelet count. They just said it's adequate. So it's not adequate. You have to ask for the platelet count. And an unexplained thrombocytosis should always be a pointer towards the Kawasaki in any other, if it is not unexplained. A low albumin, ALT levels, then leukocytosis with neutrophilic leukocytosis, and occasionally you can have a sterile pyuria. We have encountered patients of Kawasaki disease being treated as UTI, and definitely the echocardiography finally helps in solving the diagnosis. So these are some of our experiences, in unusual presentations, nephrotic syndrome, macrophage activation syndrome occasionally we have encountered. This was a patient with bilateral ptosis. On receiving IVIG, you can see the improvement in this baby. This was an infant with Kawasaki disease. This was rather a neonate, a 22-day-old baby who had presented with fever for 7 days, the mucositis, the rashes, and the unexplained edema. And there were giant aneurysms over here, you can see on the echocardiography. So this is one of the earliest reported patients of Kawasaki disease, a 22-day-old baby. Shock syndrome. So this is one of the recent presentations, myocarditis and shock syndrome. So presenting with hypotension, with very high inflammatory markers, and occasionally multi-organ dysfunction. And these are the patients, usually they'll end up in the PICUs. So the intensivists should be aware of this condition, an unexplained shock in a child. So think of Kawasaki, think of a myocarditis. So this was a 2-month-old baby with the fever for 15 days, no other finding, just an unexplained thrombocytosis. And this baby had giant aneurysms, multiple giant aneurysms, including a thrombus in one of the aneurysms. And this was again the sad story of a child who presented with fever, incomplete Kawasaki, infancy. The fever subsided. So Kawasaki, we all know, is a self-limiting vasculitis. Even untreated, the fever may subside by about 15 days. And this child subsequently presented with a swelling in the axilla. It was diagnosed to be lymphadenopathy, but then the person who did the USG said it's a vascular swelling, and you can see the giant aneurysms in the axillary artery along with the aneurysms in the iliac arteries. So Kawasaki disease with multiple giant aneurysms in some of the big arteries. So what is not Kawasaki disease? A lot of infections can mimic Kawasaki disease, especially the streptococcal and the staphylococcal infections with their toxin features. Stevens-Johnson, serum sickness. So this was a child who presented with features like Kawasaki disease, but had a big pneumonia. So this was a pneumonia mimicking Kawasaki disease. Another patient presenting with Kawasaki-like features, but only there was an abscess in the labia. So it was a toxin-mediated feature of Kawasaki. Scrub typhus can present with features of Kawasaki disease. Sometimes it's very difficult to really distinguish but one of the pointers is a low platelet count. Scrub usually has a normal to lowish platelet count. And majority of the patients of scrub, they have some encephalopathy-like features, rather drowsiness. In KD, it is more of an irritability. Occasionally, you encounter systemic arthritis, which mimics Kawasaki. So a patient, usually they are infants or toddlers, presenting with fever and raised inflammatory markers. Occasionally, arthritis, 10 to 15% of patients of KD can present with arthritis. The echo may show transient coronary dilatations, and they are usually IVIG resistant. So why identify KD? We said that it's a self-limiting vasculitis, but untreated, almost 20 to 25% incidence of coronary artery aneurysms. Remember, that is the commonest cause of myocardial infarction in children, and majority of MI occurs within the first year of onset with a mortality of 20%, because MI in children is difficult, it's very difficult to diagnose. So distribution of the arteritis, it is usually a medium vessel disease, and somehow or the other, the coronaries are the most commonly affected. So just someone asked about the histological characteristics. It's the medium-sized arteries, and very important is asynchronous affection throughout the body. So there's no mixture of acute and chronic lesions. It's like a storm. And the majority, they have a macrophage, and the neutrophils are the main components of the infiltrating cells. And there's no fibrinoid necrosis, there's no immune deposits. So just look at the morphogenesis. So it starts off as an edematous dissociation of the tunica media around the 6 to 8 days, and progresses to aneurysm formation by around 12 days. So peak coronary dilatation occurs at an average of 14 to 15 days from the onset of fever. Among patients with a normal initial echo, 10.2% recorded an abnormal follow-up echo. So that is the importance of the follow-up echos. Among those with abnormal initial echo, 27 to 32% experienced an increase in the Z-score at follow-up. Of all patients with dilatation at the convalescent phase, 23% had normal initial echo. So that is the importance of follow-up of these patients. So one should follow up these patients definitely by echocardiography, and a normal echo at diagnosis does not rule out a subsequent involvement. The goals of therapy: control of the acute inflammation and prevent long-term sequelae. The treatment is standardized intravenous immunoglobulin 2 grams per kg along with aspirin. So dose of aspirin, presently most of the centers have moved away from the higher doses. So it's either 30 to 50 mg per kg, and some of the centers are even using the antiplatelet dose of aspirin from the very beginning. So timing of IVIG, so that remains controversial. As soon as you diagnose, give the IVIG. Kawasaki is a clinical diagnosis. Even if you cannot do an echocardiography at diagnosis, and remember that echocardiography should ideally be done by a pediatric cardiologist, because otherwise the coronary involvement is missed. So the timing should be as fast as possible, preferably within the first 10 days, but there's nothing sanctum about this 10 days. So if a patient even presents late, but with persistent fever, raised inflammatory markers, do not hesitate to administer the disease, administer IVIG. And it reduces the incidence of CA to 1 to 5%, and usually very, very prompt defervescence. So if a patient does not respond, the IVIG non-responders, 10 to 15% of patients will not respond to the first dose of IVIG. So the options are, you give a second dose, but again 30% will not respond to the second dose. Pulse methylprednisolone 30 mg per kg per dose for 1 to 3 days, and infliximab. We at our center are presently using infliximab for the last 3 years. So, and there's a lot of data now, real world data, which shows that infliximab is a good therapy. It's a safe and effective drug for treatment of IVIG refractory KD. So steroids role was always controversial, but presently since the publication of the RAISE study in Lancet, so steroids are also part of the protocol. So addition of prednisolone to the standard regimen of intravenous immunoglobulin improves coronary artery outcome in patients with severe coronary artery disease. And this was a publication in last year from if a patient presents with aneurysms at diagnosis. So over there, you have to intensify the treatment along with IVIG. You have to give either infliximab or corticosteroids. So just a word from Professor Surjit Singh, what he wrote in Indian Pediatrics. To the uninitiated, the diagnosis of KD may seem like an enigma. There seems to be more of art than science in arriving at a diagnosis. KD remains a purely clinical diagnosis and for the hardcore clinician. It cannot be overemphasized that the diagnosis rests on the recognition of a typical temporal sequence of a constellation of clinical features, with none of the features taken individually being of any diagnostic significance whatsoever. So any child with fever and the classical features, infant with disproportionate irritability and persistent cry, remember that can be a presentation of KD, infant with PO, fever with unexplained thrombocytosis, raised inflammatory markers, a child with unexplained shock, cervical lymphadenopathy with rashes, and I think the list goes on. Think of Kawasaki disease. You have to think of the disease to diagnose the disease. So this is some of the pictures from our Indian delegates at the Kawasaki disease, the 12th International Kawasaki Disease Symposium 2 years back in Yokohama, Japan in 2018. You can see some of the luminaries, including Professor Surjit Singh, who's, I think, can be considered as our Indian Kawasaki. And this is my fanboy picture with the great man. So before I end my presentation, just a word from Kawasaki, Dr. Kawasaki. Be strict and sincere to medicine, be kind to heartwarming to patients, and reading textbooks and papers is important, but seeing patient carefully is much more important. Thank you. Thank you, sir.
Thank you, Dr. Paul. I would now introduce Dr. Amitabha Chattopadhyay. Dr. Amitabha?
Good evening. Am I audible?
Yes. Yes, sir, you're audible. Yes. Yeah. Good evening, sir. And for the others, I would like to give a brief introduction. This is Dr. Amitabha Chattopadhyay. He's the Senior Consultant Pediatric Cardiologist at Narayana Super Specialty Hospital, Howrah, Kolkata. He's done his MBBS followed by DCH, DND Pediatrics, and a fellowship in pediatric cardiology at the Children's Hospital Westmead in Australia. Dr. Amitava, I welcome you, and we are looking forward to your session, sir.
Good evening, everyone. Thank you, Jivantika and Priyankar and all the organizers. So, Kawasaki disease, I would like to speak from the on behalf of a cardiologist. There is a cardiologist perspective. So, clinical features, I'll directly go to the clinical features of the cardiovascular manifestations what we really have. Like as Priyankar has depicted, apart from the other clinical features, I would like to concentrate only on the cardiac part. During the acute phase, the patients may manifest signs of myocarditis, though it is rare. Even the children may present in a shock state, sinus tachycardia, which is out of proportion to the fever, a gallop rhythm, or muffled heart tones, presumably because of some dysfunction or some pericardial effusion. But these are generally self-limited and improve with IVIG treatment, and overt heart failure may occur occasionally. So the levels to distinguish whether the child is having some sort of a myocarditis or it is part and parcel of the disease process, we can do a pro-BNP and a troponin I, though these are not routinely done unless and until we really suspect that the child is having some cardiac dysfunction. And they can be elevated in the acute phase, though the correct clinical significance is not routinely tested in this kind of a patients. A pericardial effusion by echocardiography is also not uncommon. Generally, it signifies some amount of serositis, which is part and parcel of the serositis of the Kawasaki disease, which is a multi-system disorder, as Priyankar told, but generally it's less than 1 millimeter. And tamponarchy is very rare. Systolic murmurs increased audible due to increased cardiac output and anemia, and mitral regurgitation may be seen in 1/4 of patients. This is because of some sort of a valvulitis, and obviously because of the dysfunction, volume overload, we can have mitral regurgitation because of ring dilatation. Children occasionally present with low cardiac output shock, and the risk factors for this presentation there may be associated with GI symptoms as well, which can be a surrogate marker for risk factors. Coronary arteries. These are of prime importance as a cardiologist because these are the main owners of a Kawasaki disease, whereby we can have coronary artery changes in all shorts and frames in a case of Kawasaki disease. Coronary artery dilatation or enhanced perivascular brightness may be seen in 30 to 50% of patients, which is one of the mainstays and the diagnosis of the Kawasaki disease. Though in the recent classification, this has almost been given up because it is very, very individualistic. Whatever may be the enhanced perivascular brightness to me may not be so to any others. So we try to give less than importance to this one nowadays. During the activities of the case, this can be seen up to 30 to 50% of patients. Without IVIG treatment, the coronary arteries may become aneurysmal within a period of 1 to 3 weeks from the onset of illness, with an average, say, of 7 to 10 days. That is the reason if the echocardiogram is done within the first week, many a number of times we can get a normal echocardiogram only to find an aneurysm in the third week or even later. Sorry. Reported rates of aneurysm vary based on the definition of an aneurysm used, which are different according to different criteria. The Japanese National Kawasaki Disease Surveillance data produces incidence of CA dilatation is about 7.26%, aneurysms about 1.04%, and giant aneurysms is less and is approximately 0.24%. The Pediatric Health Information System, an administrative database of freestanding children's hospitals, which rates the aneurysms between to 5.9%. Now, the coronary aneurysms, most frequently they are seen in the proximal segments of the LAD and the RCA, and the less commonly seen in the LMCA. The circumflex is the least often involved. Again, an aneurysm in the distal artery segment is usually, but not always, accompanied by an aneurysm in the proximal segment of the same artery. What is the applied importance? The applied importance is, for example, to diagnose any case of Kawasaki's disease, we always look forward to any aneurysms, which are obviously the echocardiography limitations are that we can see only the proximal segments of the coronary arteries. When the coronary arteries take the bend and twine round the heart, it is very difficult to find out if there are any coronary artery aneurysms in the distal part. Likewise, if you stand on the banks of a river, we can see the proximal segment of the river as long as the river is not taking a bend beyond the horizon. But obviously, we cannot see the part of the river which is beyond the horizon when the river takes the bend. This is the segment which we normally use to make the things explainable to the parents. And aneurysms with internal diameters of more than 8 millimeters or Z-score of more than 10, that is a giant aneurysms, are disproportionately carry a higher risk of myocardial infarction. So the risk scores for the development of coronary artery aneurysms, are there any risk factors, whether we can predict something? Yes, based on the clinical and laboratory data at presentation, there are independent factors are that protracted fever, presumably reflecting worse vasculitis, anemia, elevated WBCs, low albumin, elevated CRPs, male gender, age less than 1 year or more than 9 years, and the largest baseline coronary artery diameters if possible. Rarely, KD patients experience myocardial infarctions as well. The myocardial infarctions present differently in childhood compared to adults, with the most common symptoms being shock, chest pain, vomiting, inconsolable crying, and abdominal pain. And these factors are very often, they're very, very difficult for the parents to pay heed to. And they, in any part, and the child, a crying child, may have different reasons. Especially, it has been reported that recurrent left utalgia can even be a manifestation of myocardial infarction. Chest pain is reported much less frequently in children younger than 4 years of age, and about 1/3 are asymptomatic at the time of infarction, and which may happen at rest or during sleep, and infrequently during exertion. And the first episode fatality of myocardial infarction has been reported to be as high as 22%, with progressively worsening mortality rates. Now, the giant aneurysms are receiving the higher rates of mortality, rarely rupture causing sudden death, though the reports are very, very less. In general, late consequences of KD are isolated to cardiovascular disease and occur only in patients who had coronary disease at presentation. Overall survival rates at 10, 20, and 30 years after the onset of KD have been reported as 95, 88, and 88 respectively. Now, the electrocardiographic features during the acute phase of the KD, the ECG may show sinus tachycardia, prolongation of PR and corrected peak intervals, decreased QRS voltage and TUF flattening, presence of large aneurysms leading to acute myocardial infarction, manifested ST elevation in burst waves. Thrombosis of an RC aneurysm may produce a silent posterior wall infarction, abnormally deep Q waves in 2, 3, and ABI. This is an example where This is one of our patients who had a myocardial infarction at the age of 3 years, and as you can see, it was an antival infarction. There are Q waves here, which never did quite recover. Now, the radiological features, chest radiograph is usually unremarkable. The echo features to look for and findings of perivascular brightness, mild coronary artery ectasia, lack of tapering, and relatively common in the acute stage. With decreased LV contractility, diastolic dysfunction, valvular regurgitation is mostly in the form of mitral regurgitation. Later on, aortic regurgitation may occur in the chronic phase. This is an example where one of our patients actually presented with dysfunction. You can see the left ventricle is dilated and the patient has presented with dysfunction. In one of the other cases, this is an example of the perivascular cuffing where the wall of the coronary artery seems to be thickened and more bright compared to the adjacent ones. This is a case of a Kawasaki disease. It is actually on the convention should not measure at the very beginning of the coronary artery, and preferably we should zoom the echo to minimize the chance of errors. This is a perivascular cuffing and the dilated coronary arteries. This is the LAD and the circumflex, and in here you can find there was some amount of dysfunction in the later half. There is a patient who presented with dysfunction and dilated LAD with some amount of mitral regurgitation, as you can see. The next one, this is one of our prize patients. You can see the right coronary artery is dilated, is about 4 millimeters, and the left coronary artery actually houses a giant aneurysm with completely occluding thrombus measuring 13 into 16 millimeters. This is the thrombus which had actually occluded the left main coronary artery. This patient presented about 2 years after he had Kawasaki's disease with the clinical diagnosis of dilated cardiomyopathy. And when we were trying to find out what was the reason of the dilated cardiomyopathy, we found out that this child, we took the history from the mother, he had symptoms like Kawasaki's disease, resembling Kawasaki's disease, and had a giant aneurysm which was completely occluded with the thrombus, and hence he had presented with the post-mitral infarction dilated cardiomyopathy at the age of 3 years. This is a pediatric multisystem inflammatory syndrome which recently came to our hospital. As you can see here, there are dilated coronary arteries which are more than 2.5 z-scores for the child, 3.39 millimeters, and on the right side, this was the findings. And surprisingly, these findings came down within a span of 1 month when we examined the child later, 1 month later. So echocardiogram is usually done 2 to 6 weeks after the onset of the illness to understand the extent of the coronary involvement and guide the therapy. New abnormalities are unlikely to be detected at 6 weeks if the initial echocardiogram was uneventful, with normal coronary arteries at baseline and at 2 weeks. So at 6 weeks, usually we do not expect unless there is some catastrophe. But echo is done more frequently in more complicated clinical courses. For example, in large aneurysms or even giant aneurysms, we do twice weekly early in the disease, or then weekly and monthly and every 3 months for the first year, further to understand whether it is getting thrombosed or not. The global left ventricular function, regional wall motions, competency of the mitral and aortic valves, proximal segments, distal segments are usually difficult to visualize. Now, Japanese Kawasaki Disease Research Committee, what are the standards by which we measure? By these standards, by the Japanese standards, if the internal diameter is more than 3 millimeters in children less than 5 years, and more than 4 millimeters in children more than 5 years, more than 5 years of age, or the internal diameter of a segment is more than 1.5 times that of an adjacent segment, or a coronary artery is clearly irregular, then we can find it and classify it as abnormal. Nakano et al. In his paper showed that angiographically measured coronary artery diameters correlated with the BSA. Now comes the role of the z-scores, which are actually calculated on the statistical methods. If the BSA is less than 0.5 meter squares, coronary arteries measured usually less than equal to 2.5 millimeters. From 0.5 to 1 meter squares, coronary arteries measure 2.5 to 3. If the BSA was more than 1 meter square, they measure more than equal to 3 millimeters. They published the normative coronary artery dimensions by echocardiography with wide range of values, and in 2010, et al. They showed that the BSA characteristics are more acceptable and they give more closer results. Dhrubajyoti et al. Adjusted the BSA adjusted internal diameters were published, and 27% showed that 27% of the normal coronary arteries by the Japanese criteria were actually abnormal and enlarged at least by 1 coronary artery when the z-score was more than 2.5. So the alternate aneurysm classification schema were found out, and the Z-score, by the Z-score method, a small aneurysm becomes a more than equal to 2.5 to 5 Z-scores, large aneurysms more than 5 to less than 10, and the giant aneurysm has a Z-score of more than equal to 10. So you can see that the evolution of the coronary artery measurements according to the need of the day and the need of the hour. Now, from a cardiologist perspective, in the acute stage, when were we called for? We were called when there is a management of the coronary thrombosis. Apart from the diagnostic part being over, then comes the management part. Obviously, Priyankar and Shupanandi will be telling you about the management part. Of the specialist cardiological part, I'd like to give you one example. This baby came to us from another hospital, age of 5 weeks, and we found that the child was having Kawasaki disease with aneurysms, and there was a clot in the LAD. To our horror, there was a clot in the LAD. Now, the protocol says that the correct method to get over the clot is to go for cardiac catheterization and streptokinase or multiplex therapy. But this baby was only 5 weeks, and we didn't have enough of the hardware. And it has been mentioned in the protocol that if we cannot go inside, then we can just go for multiplex therapy. That's what we did. We went for recombinant tissue plasminogen activator therapy, and we found out that gradually the clots became smaller and the child was discharged on low molecular heparin and aspirin. The cardiac cath is not immediately possible if the patient is too small. We can start multiplex or RTP at 0.5 milligram per kilo per hour intravenously for 6 hours with low dose aspirin, therapeutic heparin infusion to achieve a PTT of 50 to 70 seconds. Third case, when the cardiologist called for, though this is basically an intensivist area, but management of a cardiogenic shock. Rarely, Kawasaki disease patients can present with cardiogenic shock with the need for intubation and ventilation, regular inotropic supports, diuretics to reduce the preload and afterload reducing agents like milrinone, GTN, and resembling. Cardiac catheterization and angiography, the role of cardiac catheterization and angiography doesn't come in the acute one. So gradually we are going into the phase where the patient has been diagnosed, acutely managed, and on the follow-up of a cardiologist and a pediatrician. So cardiac catheterization and angiography are done to for the prognostication and the therapeutic purposes. Whenever there is an echo evidence of large or multiple coronary aneurysms, or with clinical ECG or stress test evidence of myocardial ischemia, we usually go for a cardiac catheterization by the protocol at approximately between 1 to 2 years. But elective catheterizations are not recommended in the acute phase, mainly because lack of additional information gain. We gain most of the information by echocardiography, and there is a higher risk of arterial complications seen in acute AD. So emergency cath may be necessary for therapeutic decision-making cases where coronary thrombosis is suspected, as the example which I showed. LV-EDP may be measured, but obviously the LV-EDP can be measured indirectly by echocardiography, so it is of not much use. If cath is necessary at all, the safety and efficacy has to be established. Selective coronary arteriography is advantageous over an aortic root injection because it gives visualization of the aneurysms, obstructions, and collateral arteries. Planning the treatment and post-treatment evaluation for CABG and thrombolytic therapy, and interventional catheterizations can be used for revascularization patients. There has been papers where there has been acute stenosis, especially in the areas immediately following the dilated part, where there can be an acute stenosis leading to myocardial infarction. So this is an example of the patient whom I showed, who was having a completely occluded left main thrombus. Here you can see that the left main coronary artery has been blocked, and the right coronary artery through the collaterals and the retrograde perfusion is maintaining the myocardial perfusion. And this is the second shot where you can see this in another angle. So the left main coronary artery is totally blocked. This particular child had a CABG done, there is coronary bypass grafting done from the left internal mammary artery to the left system at the age of 8 years. This is another example of, this child came to our hospital. There's an aneurysm in the LAD, and there's another aneurysm here just beside the left main coronary artery. There's another aneurysm in the right coronary artery as depicted in this picture in the distal part of the right coronary artery. So this particular patient was on medical management because he was not that symptomatic. The role of a CT angiogram or cardiac catheterization is 1 year after as per the guidelines. Because CT angiogram comes in a role whenever the cardiac catheterization is not contemplated or is difficult, or the child is small, or there are other involvement. Particularly, peripheral artery aneurysms are involved. Even axillary artery or the iliac arteries may be involved. The CT, but one word of caution: the CT angiogram can only be done in a child if the speed of the CT is especially beyond 126. Otherwise, what happens? The child's heart rate usually it ranges between 120 to 140, especially when the child is agitated and the child is fearful. So that either the child has been sedated or with the use of beta blockers where to bring down the heart rate so that the child's coronary arteries can be mapped onto. But to be very frank, to get a very good coronary artery CT angiogram, we have to have a 256 slice CT. Radionuclide scan, this is an example of the child which we were talking about with left main coronary thrombosis. We found that there was viable myocardium still, and hence we went ahead with the CABG and the child is now doing well. Later on, he was having incessant ventricular tachycardia, hence he underwent a AICD implantation later on. So the treatment in the chronic phase, now the child is grown up and post Kawasaki's disease, maybe 7 or 8 years down the lane, coronary risk stratification is done regarding the long-term management. We follow the AHA guidelines regarding interim guidelines regarding the management of antiplatelet or anticoagulant therapies, restriction of physical activities, frequency of cardiac evaluation, and the types of diagnostic tests and the regular activities. Because the parents often come to us, what kind of lifestyle can the child lead? Whether he can take part in sports, especially active sports and body contact sports. The patient's overall risk may decrease or increase over time, depending on whether the coronary artery aneurysm or aneurysms undergo regression or develop an obstructive lesion. Usually it is seen, even if there are aneurysms, most of them come down with a Z-score of say 4 to 5. They usually come down within a span of 1 to 2 years. But they can lead to other problems. Now there comes the question of anticoagulation for giant aneurysms. Usually our pediatrician colleagues take care of this one. Sometimes the patient come to us. Giant aneurysms, particularly susceptible to thrombotic occlusions, the overall probability of either complete thrombotic occlusions or severe stenosis requiring surgery or even death caused by myocardial infarction, which is approximately estimated to be 7.5% per year for kidney patients with giant aneurysms. And they may be treated when they are treated aspirin therapy alone. Hence, warfarin is introduced, which likely improves event-free survival, but experiences high rates of adverse events such as bleeding, recurring transfusion, or hematoma evacuation, and despite intensive monitoring by a dedicated pediatric anticoagulation team. And the patients with giant aneurysms, the warfarin usually it is treated as if equivalent to a mitral valve replacement therapy, mechanical prosthetic mitral valve, and the INR is kept around 2.5 to 3.5. Children with a history of coronary thrombosis sometimes manage the triple therapy, warfarin, aspirin, and clopidogrel. So the coronary risk stratification by the AHA, if there is no coronary artery changes at any stage of illness or even a transient coronary artery ectasia, I marked it as green, where the pharmacologic therapy is not needed beyond the first 6 to 8 weeks. They can have no restriction. They do not have any restrictions in physical activity, and on the long run, no long-term recommendations are done. They can undergo, no invasive tests are recommended on the long run. And cardiovascular disease assessment, the counseling can be done at 3 to 5 year intervals. But if they have one small medium coronary artery aneurysm or a major coronary artery, they have to be on low dose aspirin until the aneurysm regression is documented and physical activity gradually is slightly restricted. Follow-up diagnostic testing, they have to have an annual cardiology examination with echo, ECG, X-ray, and regular counseling with biennial stress test and evaluation of microperfusion scan. If there are more than one large or giant coronary artery aneurysms, they have to be on warfarin with the target INR of 2.5 with additional heparin and or aspirin, biannual checkup with echo, ECG, and annual stress evaluation with myocardial perfusion scan, and an angiogram approximately 6 to 12 months. And if there is a coronary artery obstruction, which is very rare though, they have to be on long-term low-dose aspirin, warfarin, or NMWH, and contact or high contact scores should be avoided. Biannual follow-up with angiography recommended to address the therapeutic options. So these were in summary, the cardiologist aspect. On the very long run, for example, when this same person grows up and carries a married life, and they enter the second phase of life, as Priyankar was telling, on the long run, these people have been noted to have more of an atherosclerotic flux. So the recent recommendations say that they have to be on atorvastatin or lipid-lowering agents as well, so that the plaque formation and the thrombus formation are decreased. Thank you very much.
Thank you, Dr. Amitava. Warm good evening to the other doctors who are attending the webinar. Quick suggestion from all of us. There's a button known as Ask Questions. Please could you ask your questions to any of the doctors, to Dr. Priyankar Paul, and please mention to which doctor the question is addressed to. You can mention Dr. Priyankar Paul and you can cite your question. And during the FAQ session, we can address these questions. Now I would like to introduce the next speaker, Ms. Dr. Suparna Guha ma'am. She's done her MD and diploma in rheumatology. She's currently a professor as a pediatric medicine, and she has a special interest in pediatric rheumatology. And she's currently working with Vivekananda Institute of Medical Sciences. Over to you, ma'am.
Can you hear me? Hello, can you hear me?
Yes, ma'am.
Shall I share screen?
Yes.
So very warm evening to all the audience. After the enchanting narration by both Dr. Priyankar and Dr. Amitava, I will take you through an unknown territory. We will tread through an unknown territory, the inflammatory multisystem disorder occurring due to SARS-CoV-2 infection in children. Though it shares some clinical features with common pediatric inflammatory disorders, in the next 20 minutes, we will try to unravel some of the mysteries of this very less known syndrome. So let us go back to mid-December 2019. The SARS-CoV-2, popularly known as the novel coronavirus, strikes the city of Wuhan in Hubei province of China. And within days, the entire city is under a deadly lockdown. End of December 2019 and beginning of 2020, when the entire world is busy ushering in the new year, the virus spreads slowly, affecting almost every country across the globe. Adults, mainly the older people with comorbidities, are the ones which are hit most. They suffer from pneumonia, severe lung damage, ARDS, respiratory failure, and even multi-organ inflammation. We pediatricians keep our fingers crossed. There are hardly any cases of critical illness reported in children. We believe that children are either asymptomatic or they have mild to moderate infection. This is one of the earliest studies which looked at the effect of COVID-19 infection in children. From, I think, 1,500 cases, 728 were lab confirmed cases. 90% of them were asymptomatic. Only 10% developed serious complications, and they were mainly small children less than 1 year of age. Fast forward to April 2020, 27th April 2020, doctors at the working at the National Health Service issue an alert regarding multi-system inflammatory syndrome, which is occurring in children all across the United Kingdom. But surprisingly, compared to their adult counterparts, these children do not have serious lung complications. In fact, the chest X-ray showed little or no changes at all. They are coming more with severe acute abdomen, shock, hypotension, and even kidney injury. In fact, one of the earliest publications about this syndrome was actually from the United Kingdom, where the authors reported a cluster of about 8 adolescents who previously held later on developed multi-system inflammatory disease as a result of SARS-CoV-2 infection. But we needed more data to substantiate this diagnosis. Meanwhile, reports started pouring in from all across the globe. We had similar case reports from Paris, from Italy, from New York, and also from our own country, India. So what were the pediatricians seeing commonly across the globe in these children? These children were mainly adolescents in the age group of 10 to 15 years. Majority of them presented with acute abdomen.
Excuse me, ma'am. Sorry to interrupt you, ma'am.
Yeah.
We are not getting your voice properly, ma'am. Can you be loud, please? And also adjust your camera also, ma'am. Little bit down.
Right?
Yeah, thank you. Yeah, and
Majority of these children were actually coming with acute pain abdomen, They had hypotension, shock, and a handful of them also developed some features of Kawasaki disease, like they were having conjunctival injection, a rash, and even oral mucositis. Like these pictures on the right side of the screen, they belong to an 8-year-old girl who had come with a history of fever for 8 days, and later on she was found to have Kawasaki disease along with a SARS-CoV-2. Echo in these children pick up left ventricular dysfunction, and in 15 to 20% of cases there may be pulmonary dilatation. Surprisingly, RT-PCR is positive only a small fraction of these cases. Majority of them show a positive antibody response of hyperinflammation. Is it due to the injury by the virus itself, or is it due to a cytokine release resulting in a hyperinflammatory reaction? Remember, these children started developing the syndrome actually a month after the COVID-19 peak in the respective countries. Majority of them, they tested negative for the virus by RT-PCR, but were positive for the antibody. So this suggested that instead of direct viral injury, some immune-mediated mechanism was playing, resulting in this multi-organ dysfunction. So possibly there was a close interplay of cell-mediated and antibody responses. These antibodies either formed immune complexes, or they might have facilitated the direct entry of the virus into the tissues like heart and infections, or they might have been a cross-reactivity with the viral antigen, giving rise to an autoimmune reaction. T cells also might have mediated the tissue. In a nutshell, SARS-CoV-2 caused mild infection in those with a normal immune response, and those who had an abnormal immune response mounted high titers of non-neutralizing antibodies, resulting in lung injury and even febrile illness resembling AIDS. 14th May 2020, CDC, which is the Center for Disease Control in the United States, issued the case definition for pediatric inflammatory multisystem syndrome. Meanwhile, WHO and the Royal College also came up with their own definition. So when do we start suspecting that a child has hyperinflammatory syndrome due to SARS-CoV-2? A child who is presenting with persistent fever has marked inflammation. There is evidence of single or multi-organ dysfunction in the absence of any microbial cause, and showing evidence of SARS-CoV-2 either by a positive RT-PCR or an antibody, or has a history of contact with a suspect within 4 weeks of developing the syndrome is known to suffer from this disease. So in a nutshell, all these children have persistent fever. Most of them have hypotension, they require oxygen, and a handful of them usually come with GI symptoms. They may then have neurological symptoms like confusion, headache, or as I mentioned before, KD-like symptoms. Among the laboratory markers, the inflammatory markers are very high. There is characteristic lymphopenia in the background of neutropenia. The CRP is very high compared to the total, and there is high D-dimer too. The ferritin is high, but it is not so high as we commonly see in a cytokine storm. This was a retrospective study conducted across 14 centers in France and Switzerland. 35 children with acute heart failure from different pediatric intensive care units were selected for the study, and it was seen that 31 of them were positive for SARS-CoV-2 by RT-PCR. All the children actually initially presented with fever, and the commonest gastrointestinal symptom was fever, was pain abdomen, and loose stools. They had a high NT-proBNP, D-dimer, and a CRP. This is the latest and I think the largest study on PIMS, which came out recently in June in New England Journal of Medicine. This study was conducted across 26 states in the USA. 186 children with PIMS were studied, and SARS-CoV-2 was positive in 70% of the children. The commonest organ involved was the gastrointestinal symptom, followed by the cardiovascular. Surprisingly, they saw that some of these children, about 40% of them, developed features of Kawasaki disease, and in 8%, echocardiography picked up the coronary artery aneurysms. So definitely this new syndrome we see shares features with Kawasaki disease, toxic shock syndrome, and macrophage activation syndrome. So basically, SARS-CoV-2 actually causes a wide spectrum of immune-mediated syndromes in genetically susceptible individuals. This may range from a febrile illness having KD manifestations to a more serious disorder having a multi-organ involvement like PIPS. And these are the three phenotypes due to SARS-CoV-2 infection occurring in children. Classical KD is seen in the younger children, less than 5 years of age. They have high incidence of coronary aneurysms and are very refractory to the conventional therapy. PIMS, on the other hand, occurs in older children. They present with GI manifestations. 80 to 90% of them actually come with acute abdomen. Some may also develop headache, confusional states. Hypotension and refractory shock is also seen in about 60 to 70% of these kids. Echocardiography picks up left ventricular dysfunction, and the smaller proportion of cases there may be occasional coronary dilatation. SARS-CoV-2 may result in florid cytokine storm giving rise to macrophage activation syndrome, but the children are usually older and they usually present with serious lung manifestations like their counterparts. This was an observational study from Italy. The Bergamo province of Italy showed a sharp spike in the number of Kawasaki disease cases in the months of, I think, April, May, post-pandemic. The authors then did an observational study. They divided the children into two groups. Group 1 actually consisted of children who showed KD features before the pandemic. And group 2 actually consisted of children who developed KD features after the pandemic. And it was seen that when these two groups were analyzed, the post-pandemic group showed more evidence of shock, more evidence of macrophage activation syndrome compared to the pre-pandemic KD group. Even the group 2 had significant lymphopenia, low platelet, hyponatremia, and they also developed significant echocardiography changes. So the key messages which we get from this study is that PIMS definitely shares features with KD, but there are certain differences. And what are these differences? These children are usually older in age, adolescent age. They were usually seen to be Africans, Afro-Caribbeans, or Hispanics. On the contrary, these children coming from East Asian ancestry showed lesser incidence of PIMS. Apart from the mucocutaneous manifestations, the major findings seen in these children was GI symptoms. They were usually coming with acute pain abdomen. Remember, myocarditis is seen in 100% of KD cases, but only 5% go on to develop KD shock. On the other hand, children having PIMS develop symptomatic myocarditis, giving rise to hypotension and shock in about 70 to 80%. Echocardiography picked up left ventricular dysfunction. The left ventricular ejection fraction was low. Regarding the incidence of coronary artery aneurysm, it is not known whether there is significant difference in the incidence of aneurysms between the two groups, but definitely these children, those the PIMS group who even did not show KD features, developed some amount of coronary dilatation. And compared to the classical KD, they had lower platelets, lymphopenia, and a very high CRP and D dimer. Vast majority of children with SARS-CoV-2 usually have mild symptoms, and their outcome is excellent. Only a small fraction of them need hospital admission. Those who have severe respiratory distress coming with neurological symptoms, or even with renal or hepatic injury. So once these children are admitted, we have to quickly look for multi-system involvement, start empirical antibiotic therapy as the local protocols, and to have to start immune modulator therapy as soon as possible. So the line of management is the immune modulatory treatment and anticoagulation. So once we have ruled out possible infectious and non-infectious etiologies, we begin with intravenous immunoglobulin 1 to 2 grams per kg with close cardiac monitoring. If the child does not respond, fever persists, instead of repeating a second dose, we can move on to IV methylprednisolone 10 milligram per kg for 3 doses. And if the child still has fever with persisting inflammation, there is refractory shock, you are highly dependent on your inotropes, then you've got to hike up your immune suppression. The choices are your biologics. Anakinra IL-1 sadly is not available in our country. We have to do with tocilizumab. The dose is 8 milligram per kg. If there is no response, you can again repeat it after 12 hours. And the maximum dose permitted is 800 milligrams. This was a beautiful paper from Indian Pediatrics, which studied the effect of intravenous immunoglobulin and tocilizumab in a child with hyper-inflammatory syndrome due to SARS-CoV-2. Regarding antiplatelets and anticoagulation, there is no role for prophylactic antiplatelet or anticoagulation in PIMS. If the child has predominant KD features, you have to give aspirin in a dose of 30 to 50 milligrams per kg. But if it is PIMS with some KD features, you can do with 3 to 5 milligrams per kg aspirin. Anticoagulation, you reserve for those with documented thrombus, a giant aneurysm, or with a very low left ventricular ejection fraction. These children have to be closely monitored for deterioration of clinical symptoms and for worsening of the laboratory parameters. The key approach to diagnosing and recognizing the cytokine storm in pediatric SARS-CoV-2 patients, the mantra is check, is test, test, and test. You've got to check your labs very frequently and take the help of your colleagues. You have to take the help of pediatricians, the rheumatologist, the cardiologist, and after all, the interventionists too. So the take homes in this COVID era, practicing doctors, especially the pediatricians, you have to be aware of this group syndrome. Children are affected by SARS-CoV-2, contrary to our previous belief. A handful of them may develop this multisystem inflammatory syndrome. The child may walk into your OPD just with acute abdomen, or on examination you may find that she has no ulcers, hypertension, no lymphocyte count, high CRP, high TPFT, or other red flag signs. These children can be negative for SARS-CoV-2 by RT-PCR. If possible, you should preserve the blood for antibody testing later on. So I end with this famous quote from William Shakespeare in Hamlet. Diseases desperate grown by desperate means are Hello? Can you hear me?
Yes, ma'am. Yes.
Thank you.
Thank you, Suparna ma'am. Now I think the moment we've been all waiting for, the panel discussion on COVID-19 associated hyperinflammatory syndrome resembling KD. The entire panel discussion will be held by Dr. Priyankar Paul and Dr. Dhrubajyoti Sharma, along with Dr. Amitabha Chattopadhyay and Dr. Suparna Guha ma'am. Before we move into the panel discussion, a quick round of introduction about Dr. Dhrubajyoti Sharma. He's an MD pediatrics, and he's more of a clinical immunologist and rheumatologist from PGIM at Chandigarh. Currently he's an assistant professor of pediatrics at the Guwahati Medical College. Good evening, sir. Welcome to the panel.
Good evening to all. Good evening, sir. Good evening, madam.
Good evening, Jyoti.
We can start, sir?
Yeah, definitely. So I think this is the topping of the cake for the evening. Then I think Suparna has already described elaborately the newfound entity of COVID-associated hyperinflammatory syndrome. So before we go off to the panel, just to give a flavor about these patients, so I'll be presenting two cases that we happen to encounter over the last 15 days. So I'll start off with just a case presentation of two cases that I happen to encounter. So the first case was an 8-year-old girl who presented with high intermittent fever, 102 to 103 degrees Fahrenheit, with headache for the last 3 days. There was some erythematous, non-blanching, non-itchy rashes over the hands and trunk that subsequently involved the periorbital region. And there were persistent non-bilious vomiting, loose stools, and epigastric abdominal pain for the last 2 days. So this was the presentation. So you can see the rashes, a little unusual looking rashes over the palms and soles. And so this was one of the things that this rash on the finger, which attracted my attention initially, the classical Tilben-like rash that we were encountering, the pictures that we are seeing from Italy. And this was a child, the rashes have now involved the trunk, the extremities, and you can see the non-purulent bulbar conjunctivitis along with some periorbital puffiness. So the child had on admission tachycardic, the child was tachycardic, she was otherwise stable, the blood pressure was normal, just the epigastrium was tender and the liver was 2.5 centimeter. So she was admitted in the isolation ward and a COVID-19 RT-PCR was sent. And if you look at a series of investigations, so she was admitted on the 3rd. There's a neutrophilic leukocytosis. The neutrophils are very high, and the CRP is unusually high, 362 milligrams per liter of CRP. And she had also a hyponatremia. The investigations repeated after 2 days showed that she was, of course, put on broad spectrum IV antibiotics. Since scrub happens to be quite common in this part of the country, she was also put on doxycycline. But 48 hours, the fevers continued, the loose motion continued, and she continued to have very high fever and very high CRP. You can see the CRP is still hanging around 300. And what was another thing, that the platelets were not very high. The platelets were in almost the normal range, and the sodium was always persistently low. So now in the meantime, the COVID-19 PCR came to be negative. She was shifted to the ward, and what was noticed that she had a persistent tachycardia. She was a disproportionate tachycardic, and even in the sleeping pulse rate was high. So that was something which was unusual, and that was what made us think that is she having an underlying myocarditis. And so she was asked for an echocardiography, and the cardiac enzymes were also ordered. You can see that the NT-proBNP was sky high, 13,343. The D-dimer was also high, and also procal was high. And the echocardiography showed an ejection fraction of around 45%, and the LMCS-Z score was just +2. So you can see the just dilated coronaries over here. So Dr. Anil Singh, who did the echocardiography, was kind enough to share the picture with me. So now we were almost certain that we are dealing with a hyperinflammatory syndrome. IVIG was initiated at 2 grams per kg along with low-dose aspirin. And at this time, the child also started having hypotension. So the child was shifted to the intensive care in the middle of the night, and inotropes were started. But there was a dramatic change within 12 hours. She became afebrile, the BP started improving. Within 24 hours, the inotropes could be weaned off, and the tachycardia also gradually subsided over the next 36 hours. So a repeat echocardiography after 48 hours, the ejection fraction has gone up to 60%, but the coronaries, there's a marginal dilatation of the coronaries has gone up to plus 2.5. And an antibody test also was sent, and you can see that the COVID antibody was strongly positive. So this was our first patient. Around the same time, a second patient was also admitted in the intensive care unit. So this was shared by Dr. Prabhash Prashungiri, who's a pediatric intensivist. I'm thankful to Prabhash for sharing this case with me. So this is a 15-year-old boy who presented with fever for 8 days, rash all over the body for the 5 days, again redness of the eyes and vomiting. So you can see the redness of the eyes, very marked, conjunctivitis, non-purulent bulbar conjunctivitis again. The rashes, dark skin, I think that it's not very visible, but you can make out some of the rashes over here. So on admission, the big child was otherwise stable, and the investigation again picked up a very high CRP. So a very high CRP is one of the markers of this condition, a disproportionately elevated CRP. Even in KD patients, we do not usually encounter a CRP of this magnitude. And the platelets, you can see, they are almost not very elevated. And the sodium was again on the lower side. So COVID-19 RT-PCR was negative, and echo showed dilated coronaries. You can see the LMC of plus 2.4, and LAD had a Z score of plus 3.3, so which is almost like a small aneurysm. And ejection fraction was 56%. So this child was a big child, not coming from a very well-to-do family. So the child was just administered 1 gram per kg of IVIG along with methylprednisolone 10 mg per kg for 3 days and low-dose aspirin. So repeat echo after 72 hours, similar findings, but the child definitely improved, the fever subsided, the inflammatory parameters came down, and the child was discharged. Both the children, in fact, were discharged with low-dose aspirin with follow-up, with advice for follow-up echocardiography after 15 days. So, but this child was antibody negative. So we had 2 patients, almost similar presentations. One was antibody positive and the other was antibody negative. So over to, I think, Dhrubajyoti now.
Thank you, sir.
Yes. So I think one of the most important things about these patients is making a clinical diagnosis, a clinical decision, and thinking about the diagnosis. So although Suparna has mentioned it in her, but I would again request you to say what would make you think of this diagnosis.
Exactly, sir. So actually, most of the things so nicely elaborated by you, sir, and madam, and also Amitabha, sir. So nothing is left for me. I am just learning from you. And as a part of discussion, I have to repeat several of the things. And madam already had highlighted very important points. So every time we receive new data, it either helps us to learn something new or give rise to even more questions. So what is this PMIS? So several other names, it has several other names like multi-system inflammatory syndrome of children. So hyper-inflammatory shock in children. So in your cases, these 2 cases, the first case 8 years child, male child, and suddenly deteriorated during the hospital stay. Second child is 15 years, had prominent GI manifestation. I think these are very important telltale signs for suspecting this pediatric multisystem inflammatory syndrome in association with COVID-19. So how to suspect a case with this syndrome? So this syndrome should be considered in children presenting with fever without an explanatory alternative diagnosis at any of the following. That means after initial resolution of known or highly suspected COVID-19 infection or recent, that means less than 4 weeks of COVID-19 exposure. There is a duration, the lag period, that is as you have already highlighted, and systemic illnesses with signs of shock or significant abdominal symptoms like nausea, vomiting, and abdominal pain. So these all, I think, help us to suspect this syndrome. And this has been already nicely described in the case definitions by CDC and WHO. Then again, all patients with this syndrome do not develop shock, and not all patients have features of complete KD or incomplete KD. So how a pediatric multisystem inflammatory syndrome is different from KD in pre-COVID era? This also Madam has already told, but again I want to repeat it, highlighting important points. KD is most common in children less than 5 years, but PMIS is more common in older children and adolescents. And KD is common in children of Asian ancestry. However, PMIS is more common in children of blacks and Hispanics. In KD children, we do not permit this. Children with KD usually primarily do not present with abdominal symptoms, and shock is very, very rare phenomena. However, in PMIS, there's rapid deterioration with the development of shock and multisystem dysfunction in a previously healthy site. That is very important. Site is previously healthy and suddenly deteriorated. And abdominal complaints are very prominent. So in investigations, early development of lymphopenia and thrombocytopenia and marked elevation of the D-dimers and serum ferritin levels. In Kawasaki disease, lymphopenia is usually not seen. And we can see thrombocytopenia on occasional sign in the first week of illness. So these are not common in the Kawasaki disease. And the extreme end, the PMIS has shock and multi-organ dysfunction. So another phenomena in relation to PMIS is the cytokine storm syndrome. This occurs following stimulation of the innate immune system by an infectious agent. Here it is the SARS-CoV-2 virus that lead to uncontrolled release of the pro-inflammatory cytokines, that is interleukin 1b, interleukin 6, TNF-alpha. This is like macrophage activation syndrome. This is also another example of cytokine storm. So out of this, the interleukin 6, I think, responsible for most of the clinical manifestations, including fever. So cytokine storm syndrome is usually present with high grade of fever, rash, coagulopathy is there, and neurological signs, with some progressing to multiple organ dysfunction syndrome and subsequently death. So in laboratory features, we get thrombocytopenia, lymphopenia, increased transaminase levels, elevated D-dimer, LDH, coagulation time will be prolonged, and CRP will be very high, as you have seen. And serum ferritin is very high. That is similar to macrophage activation syndrome, which is another example of this cytokine storm, as I have told. So the important observations are patients can initially be well appearing with reassuring laboratory workups, only to return to the hospital days later with worsening symptoms and repeat clinical deterioration. Though the clinical picture suggests, it is unclear at this time whether it is more typical of KD, what we have seen in pre-COVID era, or it is in association with SARS-CoV-2. In an analysis of the data from New York, UK, Italy, and France, total number of children 142, that showed 63% of children had positive serology and negative PCR. 63% negative PCR, positive serology. So then 30% had positive for both, and only 8% had negative for both. That means it can be negative, as you have said, sir. It can be negative or it can be positive. And as it is an inflammatory immune reaction, so most of the time we get PCR negative. That is also right. So I think these are the very important issues we can suspect from that, and other issues like treatment we can discuss in the treatment sections. Thank you, sir.
Dhrubajyoti, will you say a word or two about a macrophage activation syndrome? Because we all have heard that some of these patients can go into macrophage activation syndrome. So just for the general listeners, so when do you suspect, and being a rheumatologist, I think you are one of the very, very well versed on macrophage. So we'd like to hear from you, just when would you suspect a mass in these patients?
Okay, sir. Sir, actually, macrophage activation syndrome, the older name was hemophagocytic lymphohistiocytosis, that was coined by hematologists. And since 2002 onward, we are that remote, that is seen that it is same. That means HLS or MAS, it is the same disease. So, but MAS we consider in the rheumatological points of view, that means associated with systemic GI or other rheumatological illnesses. And SLS is a broad term, can be infection, can be malignancy, can be rheumatological illness, can be some genetic background. So suppose, for example, in this COVID-19 infection, now before that, I want to give examples of systemic JIA, what we see in the pediatric rheumatology. So a child with systemic JIA will have leukocytosis, will have very high thromboplatelet count, maybe say million, more than million, high CRP, high ESR. So this is the clinical picture, and serum ferritin level may be high. So here, once the child start developing macrophage activation syndrome, the platelet counts, the clinical syndrome, that is fever, is one of the important point in systemic JI. So initial quotidian fever, that means intermittent fever, become persistent. That is a very important sign. Persistence of fever, then sudden drop in the platelet count, and very high CRP level, and drop in the ESR. These are the very important signs of development of macrophage activation syndrome. Though there is a criteria, that means the classification criteria for that, but this criteria is not useful for clinical diagnosis. That is for research purpose only. So I will not go into the criteria. Like that, in infection-associated HLS, like in SARS-19, we get the similar picture what we have described in the cytokine storm. There will be drop in the platelet count, drop in the ESR, very, very high serum ferritin level, maybe say more than 10,000. And ESR will be down. We can get a high D-dimer level. Clinically, again, the fever will be persistent. Another point is that we get maybe get jaundice, coagulopathy, and neurological symptoms like seizure. So like that, we can suspect macrophage activation syndrome. But I think it is very difficult in a case of cytokine storm syndrome to discriminate clinically whether it is purely macrophage activation syndrome or HLS, or it is a cytokine storm syndrome, because pathophysiologically both are same.
Okay. What I have always encountered in macrophage activation is the sudden change in the neurological features.
Exactly.
Especially in patients of systemic arthritis. They suddenly develop some amount of encephalopathy. So I think that is one of the most important clinical pointers in picking up a patient with macrophage activation. So presently then we'll ask now Amitava, the cardiologist, to give his input regarding these patients of PIMS. So Amitava, can you unmute yourself?
Yeah, sure.
Yeah. So when will you do the echocardiography? And then what are the usual findings that you can expect? So just share with us.
Yes, Priyankar, I would just like to share one of our patients who our intensive Dr. Shivagurdeep has actually managed. This is a very, very similar patient, the two which presented. This patient came, the father was a police officer, and he presented in a very bad shape with anasarca, pedal edema, edema of the hands, and facial puffiness. Not put in a state of shock with abdominal swelling, and there was gross function on echocardiogram with enlarged coronary arteries. Not aneurysmal, I would say. All the patients which we have seen a total of 5 patients. 4 were from peripheral centers sent by Dr. Praveen Bhumik, but I'm not sure whether the tests were done on them, because none of them had elevated platelets, but all of them had coronary artery changes. And the one which was admitted in a state of shock in our hospital under Dr. Shubhadeep at ours, that particular child had edema all over and was severe dysfunction with enlarged coronary arteries and present in a state of shock. Obviously, in the PICU setup, he was given inotropic therapy, after reducing agents, diabetic therapy, ventilated, and thereafter, not ventilated, this patient was not ventilated, and thereafter gradually the child turned around in about 5 days of time. And the child was discharged on about 8th day. And after 1 month, when we saw, it was very, very surprising. Within a period of 1 month, I was surprised that the coronary diameters have actually come down to normal. So unfortunately, in this particular patient, we had done a COVID-19 test, which was negative, but unfortunately, the antibody testing was not available at that point of time. So we're planning on the next follow-up, we do antibody test if they are still present inside the body. So unfortunately, that patient was not there. Now the fact is, since this kind of patients are usually presenting with a very high fever, but not all of them presented with shock. Only a few, 1 or 2 of them presented with shock. Most of them are managed in the peripheral centers with conservative management, and the one which was admitted to us did present with a shock. The most notorious findings on echocardiogram from the cardiologist perspective was there was fluid everywhere, including pericardial effusion, dysfunction, mild amount of valvulitis, and coronary changes. These are the echocardic findings. And the clinical findings we have discovered. And we have said already, with hypotension, there was sinus tachycardia, no other arrhythmias we have noted. The sinus tachycardia, one or two ectopic beats were noted, but no other sinus tachycardia. And the laboratory parameters were just as described by you. So this, from the cardiologist perspective, very luckily, the patients which we have encountered, they all have recovered. And they have taken an average span of about 2 weeks to 4 weeks for the cardiological recovery. Obviously, the body became less swell and the water came out and the water was extracted with strong amount of diuretics, and thereafter approximately about 4 weeks they all recover. We haven't made any death. Luckily, we haven't seen any death in this particular disease so far. We haven't seen.
So I think that was good that you have diagnosed and managed it appropriately. So just say something about the inotropes that you'd like to give to these children.
Yes. Since we are in a cardiological setup, so our first choice of inotropes was to keep up the blood pressure. We use noradrenaline. To keep up the peripheral perfusion, we use milrinone. Obviously, noradrenaline was supplemented with adrenaline. These were the three main ways which we use with a very high dose of diuretics. We use the diuretics with including furosemide, aldactone, and metoprolol. Other thing which we did was we didn't take help of peripheral form of diet in this particular case, and we decreased the input to almost about 70%. And that way we were able to take out almost cumulatively, we took about 4 to 5 liters of water from the child over a span of about 96 hours. That's approximately 4 days. And that third round of patient, with a huge amount of that, gave the myocardium quite a bit of rest. And later on, we discharged the child on oral furosemide, enveloped as an reducing agent, and aldactone. These are the three things we have used.
Priyankar, can I add a point?
Yeah, definitely. Definitely. Go ahead.
Amitava, I think
Yes.
these PIMS patients, they actually respond well to your therapy, I think. Though I have not experienced any, I had the fortunate of experiencing any to deal with such patient, but I think that these patients respond well to therapy, like your coronaries, they reverse quickly compared to the typical KD child.
Yes.
Isn't it?
Yes. Surprisingly, the coronaries came back with
Yes, that is also what happened to Priyankar's patient, he said.
Yeah,
Isn't it?
definitely.
The coronaries reverted to normal.
Yes. So I think we have Dr. Snehal over here.
Yes,
I believe she's
Good
from.
evening, ma'am.
Yeah, hello, Amitabha. Yeah, hello. I'm Dr. Snehal Kulkarni, Senior Pediatric Cardiologist from Mumbai and currently President of Pediatric Cardiac Society of India. In fact, I'm looking at all the data from Mumbai, and we have involved 4 major centers. And till now, we have 23 patients from 4 centers who had this PIMS symptoms and presentations. We involved the WHO criteria for enrollment into this particular group of patients. Our age was 7.2, median age was, and the range was from 5.7 to 9.4. 15 patients out of that, almost 70% of the patients presented with myocarditis-like symptoms with reduced left ventricular function and hemodynamic instability. 4 patients out of that had significant features like Kawasaki, including coronary artery dilatation, that becomes around 11%. And when we looked at the literature, I think coronary involvement is in around 9% of patients in most of the series, and we have around 11% of patients. All the patients who presented with myocarditis, we have given them IVIG 2 gram per kg, and all patients include, in our 23 patients, we had 1 mortality for the child who was 12-year-old who came with almost shock-like symptoms, severe myocardial dysfunction, and we could not revive the child. 3 patients who had significantly dilated coronary. In addition to steroids, we have given tocilizumab with complete improvement and the recovery of the coronaries to normalcy. In fact, we have written this all our data to Indian pediatrics, and it's in the process of publication. And in fact, we have seen that map of Mumbai, where Mumbai has multiple zones, where the prevalence of COVID is more in particular areas where the slums and other things are much more, and they are trying to correlate these patients' populations from which particular zone they are coming and trying to correlate that with the zones where the prevalence of the COVID is much higher. So this is our experience from the city of Mumbai, and I think when we are there in the writing of the process, we just completed in this week. Every day we are one or two patients from either of the centers. So I think we will, especially general hospitals where they have much pediatric population and pediatric intensive care units.
Now, madam, I want to ask, how many pediatric cases you have found classical COVID-19?
I think in Bombay, we have found around 4,500 cases of pediatrics. In fact, we got most of the data from the BMC, Mumbai Municipal Corporation, and they have 27 deaths. Actually, unfortunately, we do not know what the details of the deaths from the other children. In our these 23 patients, we had only one death. But the remaining deaths in pediatric population, it's really difficult because there were like multiple other government hospitals, some the private nursing homes, and it was difficult to get the data. But with these 23 patients, we have a common format how we look at them: clinical parameters, investigations, everything. In fact, some of the children, they have very high cytokine stocks, and where we have to give tocilizumab in addition to our regular therapy. And as I said, almost 70% of the patients we have given IVIG with complete improvement in the myocardial function. So that's our experience from Mumbai. It may be good actually if we can get the collective data. In fact, I was trying to talk at that time when I was trying to collect the data from multiple centers from Delhi and Chennai, Hyderabad, Bangalore, but I could not get a concrete data from multiple centers. So I tried to get it from Bombay, but in a 1 month span, we got like 23 children who were completely evaluated as per.
What about remdesivir in pediatrics? Have you used?
We have given in the elderly children remdesivir as well.
These are the patients with just COVID or with COVID, this PIMS?
These are the PIMS. And we include this WHO criteria: either they have antigen positive, antibody positive, either of the close family members, especially parents positive. So these were the three things WHO criteria has. So we have included either of the things. And to be very specific, I just tell you about how many 9 out of 23 patients had PCR positive and 7 had antibody positive. And the remaining patients have a close family member which was positive. Until that time, I think last month, we also didn't have antibody tests available in Mumbai. And all this, the recent one only had this antibodies which are positive. And some of them have very classical, the rashes which otherwise we see in Kawasaki, the involvement of the lips, the strawberry charm, the lymphadenopathy, the rashes over the palms, very classical features like what we see otherwise. But as it was discussed, most of these children are elderly, above like 7 or 8 years of age, what we otherwise would see in Kawasaki. We never saw any aneurysm. There was significant dilatation. We had criteria for defining coronary artery dilatation. Maybe it was very early in the disease process where we did not see any significant aneurysmal dilatation. The Z-scores were just +3 or something like that. And all of these coronary arteries came back to normal after IVIG.
Madam,
our experience from Mumbai.
Madam, I have a question. Are you giving remdesivir routinely to all these pediatric patients?
No. We don't give remdesivir routinely, actually.
So, madam, what is your selection criteria for the remdesivir?
This is usually, as I said, I'm not the thing of management of the Kawasaki. This is COVID in pediatrics because we have a infectious disease control. Dr. Tanu Singh will be going on. So, they decides depending upon. So, the who are like likely to be poor, they come in the ICU and has PIMS-like features, then we get involved into all these things. But now who comes with this PIMS, we definitely looked at the heart function, dilatation, coronary involvement in all. I think we need to like have a follow-up of all these patients, but by the time of discharge, most of the coronaries come back to normal.
Dr. Sagar is here. I think he should make some comments about that.
Sagar, unmute yourself.
Hi, sir. Yeah. Hello.
So what is so background, Sagar?
Fortunately, none so far, sir.
Yeah, so
I have personally not seen any case. And, so we are seeing COVID positive, I think, children, but I haven't personally seen anybody with a PIMS. But I think the surge in Bangalore has started only this month, so maybe we must anticipate in the coming month.
Yeah, that's what I feel. Once you like peak, we also initially did see Mumbai. Well, Mumbai peaked a lot and then plateaued in that particular phase. After 1 or 2 months of peaking, we started seeing many cases. So maybe a city like Bangalore, which are picking up now, maybe they see this kind of a presentation after a month or so.
Yeah.
But my one concern here is that if we label both antibody and PCR negative patients as PIMS, maybe we would end up overdiagnosing. That is my concern.
See, but if you see this as a criteria, even they have said even the close contact. That also is one of the things which need to be considered.
Again, I think it will.
That is a very, I do agree. That is very subjective. That is a very subjective kind of a thing. Close contact with the. Because we have children who are positive by PCR, but the parents are negative, So it's little difficult.
Yeah. So I think because now everyone is getting aware of this condition, as long as we have one of the tests positive or immediate family member being positive, I think we are quite justified. But then even the otherwise presenting people who present as toxic shock syndrome may be labeled as PIMS, and because then they would also respond to IVIG. That is my concern with this entity.
Yeah, and Kawasaki, we don't see such a significant myocardial dysfunction, hemodynamic compromise. Very rarely see in Kawasaki. That's the way we see it. And the cytokine storms also we don't see in male. We have very high levels of D-dimers, interleukin-6 and ferritin levels in all these patients.
Labeling cases like that actually will decrease the threshold to refer for tertiary care facility, and everyone will be aware of that condition.
Yeah,
but possibly under the certain circumstances, it will be a little better to overdiagnose rather than underdiagnose.
Exactly, sir. Exactly.
My concern is only with the label, because I think if such a patient comes, we most often would end up giving IVIG even if it is a toxic shock syndrome. But I think once we collect more data, we would probably become more wise, and it is a good call that we should do a data collection across India. I think that's
very important. We should have a common format how the data needs to be collected and the children need to be evaluated, so that at the end we can come with some kind of a consensus statement.
Definitely, ma'am. Thank you.
Thank you.
Thank you for your valuable inputs. So I think
in Guwahati also we are getting COVID-19 positive children, but none with this inflammatory syndrome, hyper-inflammatory syndrome. Yes.
Rupa will start, we'll be seeing more of them once we peak. After we peak, we'll start be seeing more of them, I think.
Yes, sir. Yes. Maybe others.
So now I think let us go over to, we have a lot of questions from the participants who are looking at this, who are following us up. So I think the first question is from Mihi. Dr. Mihi Shorter has asked, how will you differentiate septic shock from KDSS early from Kawasaki disease shock syndrome, as KDSS may not present with classic features and myocardial dysfunction is common in septic shock. So yes, Mihir, KDSS, but usually you see this, KDSS usually starts, what I have seen the children, it starts suddenly, this babies, these children usually suddenly develop this Kawasaki disease shock fever and they suddenly go into shock. Otherwise, well children without any other infective features, with the features of infection. And again, if you look at the blood parameters, the KDSS patients, they have usually a higher amount of, they have thrombocytosis, neutrophilic leukocytosis. Septic shock, occasionally you may not have that much of thrombocytosis. So it's again a clinical call sometimes. And then if you look at the orientation of the rashes, a septic shock usually have a periorbital, that erythema and redness. But in Kawasaki, you know that it's the lips that are very, very commonly involved, the redness of the lips. So, and then if you give the IVIG, even in septic shock, I think you can give IVIG, but definitely majority of those patients are very sick patients in the intensive care. So everyone gives the broad spectrum antibiotic coverage along with inotropes. And if the KDSS patients, there's a fabulous response to the IVIG. I think, Amitava, you would like to say something?
Yeah, I think from that's exactly, except the fact that from the clinical ground, the KDSS patients are a little bit younger in age, compared to the septic shock. The septic shock patients tend to be a slightly higher age group. The KDS patients, the patients who are present with Kawasaki disease shock syndrome are usually less than 1 year. They are usually, but there can be variations. And also, since they present with a mainly cardiogenic shock without a prior long history, so we can find that the cardiac markers are slightly more elevated in this group of patients. For example, if you take the NT-proBNP and the TROP-I test, these will be slightly more elevated in this case. Like in a septic shock, you can get these on, but they are a little bit later on. So if you take the cardiac panel like TROP-I, LDH, and NT-proBNP, these will be much more marked in case of KD shock syndromes. And obviously, the signs and symptoms of KD, as it depicted, like the lymphadenopathy, the congenital redness and all, these will be much more marked in KDS. These are the clinical features, and on the laboratory grounds, these are more.
Dr. Saji Philip has asked differentiation from COVID and COVID-like presentation. I think we have already covered that. Dr. Basudev Patru has asked, if the patient comes late, would IVIG work or should treat with aspirin only? No. You give IVIG if as I said, if the patient is still in the inflammatory phase. Even if the patient is coming late, the patient has fever, the patient has elevated CRP, or if the patient has an aneurysm at presentation. Late presentation, but the child has an aneurysm, go ahead and give the IVIG. It can do a world of good, and aspirin only is not the treatment. Shomik Basu has asked, in the 2-month-old infant with shock syndrome and KD, did you administer IVIG? Yes, definitely, Shomik. We administered IVIG. The same question, how effective is IVIG if administered after 10 days? That 10 days wasn't arbitrarily fixed up. So you remember you are treating an inflammation. So if the inflammatory parameters continue to be high, and if the child presents with aneurysms, you should hike up the management. Not only give IVIG, presently everyone treating KDs usually give infliximab or steroids along with the IVIG. Dr. Saji Philip has a question from Amitava. Can we give low molecular weight heparin for children for 1 year, then to oral in infant and young children since risk of MI is higher below 1 year?
Yes, we can. Yes, we can give. In fact, it is given in infants and even in neonates. It's well given. Only thing is the blood parameter to be monitored is anti-10A, which is not universally available. So we try to give it, but it is very safe medication in cases, for example, if the child has any GI disorder or has any gastroblast, and where the aspirin is contraindicated. Example, ductal-stenting patients also. In many cases, there you can use low monomolecular weight heparin. It is given twice daily, and the dose is in lesser dose. For infants, you need a little bit of higher doses because the presence of non-virulence factor and the other proteins are a little bit more in infants. As you go up on the age, the dose actually comes down. But it can be very, very safely used.
Just I would like to add, in fact, it's better to give a low molecular weight heparin because giving warfarin and maintaining that INR is almost next to impossible. Because the classic INR
is very erratic.
Very erratic. So even we have patients. We had a 2-month baby who was on low molecular weight heparin for almost 3 years, we teach the parents to administer the low molecular weight heparin, and usually the acceptance is, and the monitoring is much more better. So Sagar has asked this question already, that overdiagnosed we have dealt with. Now Mihir has asked, was viral etiology for myocarditis excluded? Mihir, these patients had very high CRP, disproportionately high CRP. So usually in other viral myocarditis, we do not really encounter this high CRP. Acute presentation under the present circumstances with the classic features described elsewhere, and this high CRP, and then the response to the classical, almost fabulous response to IVIG. No, we did not look at other viral etiology in the 2 patients that we described. Professor Apurva Ghosh has asked, Kawasaki disease following acute human adenovirus infection, sir. Definitely Kawasaki, a lot of data is that Kawasaki can be post-infections. A lot of infections has been described in association with Kawasaki. In fact, I think there's a paper from Sick Children Toronto that said that almost 10 to 30% of patients of KD some associated infection. So of course can be associated with Kawasaki disease, and Kawasaki is now maybe a syndrome. So a lot of people say that it may not be just a disease, it's a syndrome. In fact, there's just recently a paper from Professor Ravelli that Kawasaki disease or Kawasaki syndrome. Mihir Shorkar has asked again, patients resistant to IVIG and steroid, how will you select biologics among infliximab, anakinra, tocilizumab? Now, anakinra is unfortunately not available in the country. So I think usually people are using tocilizumab. I think, in fact, Dr. Snehal also mentioned about tocilizumab. But if someone has significant aneurysms, then possibly the choice will be infliximab, because the tocilizumab was used in some of the trials in Kawasaki disease, IVIG-resistant Kawasaki disease. Usually the response to fever was excellent. The children became afebrile very rapidly, but on follow-up, they had much more giant aneurysms. And that was the reason that tocilizumab was discontinued as a drug for IVIG-resistant KD. So if you have significant aneurysms in this patient, the drug of choice will be definitely infliximab, but tocilizumab in all the other patients. Dr. Abhijit Mukherjee, why MIS-C2 occurs in older children? Shuparna, will you be able to say something regarding this? Why it occurs in older children?
So what from the literature, what I gathered is that younger children, the ACE2 receptors in the nasopharyngeal pathway, they do not reach a level of maturity. And you need these receptors for the virus to bind on them and enter into your system. So that is, I think, is the reason for explanation that why the younger children, because of the immature receptors, they actually do not get such florid things manifestations. It is the older children, the adolescents, where the receptors have matured. That is, I think, the reason why the older children are having this compared to the younger children. I don't know the view about the other panelists. Dhruva, you want to add something?
No, madam, exactly the thing what you have expressed, you have told. So a C2 receptor, which is a receptor for the virus, yes. That's in the bronchial wall. So that is very important. So that is underdeveloped.
Dr. Pal had a question. Dr. Sharma.
We will go to that. Ansar Ali, Dhruva, this is for you. Timing of live vaccine in KD patient treated with IVIG and steroids?
Okay. Actually, main concern is the measles, mumps, and varicella vaccine. So usually we advise these live vaccines after 11 months of giving IVIG. Kill vaccines we can give without any problem. And for other live vaccines, I think no any problem. But only concern is the mumps, measles, and varicella.
Dr. Abhijit Mukherjee has asked tocilizumab or infliximab, which one is better? I think we have already addressed that. Dr. Amanjyoti Dasgupta, any risk stratification necessary in KD for IVIG resistant? Yes, sir. There are a lot of scoring systems. The Japanese mainly Japanese. You have the Kobayashi score, you have the Sano score. So there are a lot of, we personally at our center, we use the Kobayashi scoring system, but the scoring is accepted in the Japanese population. Outside Japan, it is not accepted universally. In fact, one of my PGs is doing a thesis on that, whether this Kobayashi scoring system applies to IVIG resistance in our population. So hopefully by some time we'll be having the results. What is the reason for large number of patients curiously presenting with acute abdomen in PIMS? Shuparna, will you take up this? The reason for this acute abdominal presentation?
So maybe this is, I think, because of the widespread vasculitis. Along with the other system, you also are having GI vasculitis, there is bowel ischemia. So basically, because I think because of this reason only you are having this acute pain abdomen, the GI vasculitis, the bowel ischemia.
Possibly, yes.
Yes.
And then he has also asked, is cytokine profile like IL-1, IL-6, TNF be a part of investigation for PIMS? When do you look for it?
No. I think you do not need to do routine IL-6 in these patients. CRP itself is a well marker for IL-6. And elevated CRP is a well indicator of your high IL-6. You do not need to do IL-6.
Actually, many of the issues can be well taken after say 2-3 months because we do not have robust data on it. Now it is we are learning. So still data are incomplete.
Absolutely.
So
why there is abdominal, I think it will be clear after
that could be one of the reasons, which I think.
A CRP is definitely one of the good things. You can do a ferritin, but if someone is willing to do an IL-6 in West Bengal, instead of childhood health is there, we are IL-6 at a very reasonable rate.
What is your cost per IL-6?
I think it's around 500.
Oh, very cheap.
It's not very expensive.
Okay,
yes.
Quite cheap. Cheaper than ferritin, I think. Cheaper than ferritin, isn't it?
So we always try to give
package. Ferritin IL-6 package.
So and a good service at a.
Okay, thank you for the information.
So Dr. Shamar Paul has asked that in patients suffering from post-COVID hyperinflammatory syndrome, when should tocilizumab be used? So, take this up.
Thank you, sir, for the question, and a very good evening to you, sir. So I think that the children who are having refractory illness, having hyperinflammation, you have fever, you have refractory shock, not responding to your inotropes, in spite of giving IVIG steroids, the call is for biologics. And since in our country we do not have anakinra, we have to do with tocilizumab, sir.
Yeah, it is a third agent after IVIG and corticosteroid.
Dr. Devang Pandya has posted, I think, let me read it out. As we know, CRP is a surrogate marker of IL-6. I came across one patient 6 years with classical KD with CRP of 180, ASR 49, with highly elevated NT-proBNP, D-dimer, and PCT. He responded to IVIG clinically dramatic but developed aneurysms. I think there's a aneurysm in the RCA, CRP reduced to 18, ASR to 89, IL-6 and GT 5000, child clinically stable now. My question is, of course, IL-6 in KD COVID patients, so that we have, I think we have answered that you need not do routinely IL-6 because another thing is that IL-6 can be variable because a lot of centers give different results, but a much more stable report is the CRP and the ferritin. He says that I came across 14 such COVID KD patients during the last 2 months. 50% investigations were not done. One RT-PCR positive, one antibody positive. But 50% children were from COVID area or containment zones, predominant GI and liver symptoms. So I think everyone is coming across this predominant GI and liver involvement and may not be positive RT-PCR. So thank you, Devang, for sharing your data. Dr. Bhupendra Manocha has asked, why is it that this hyperinflammatory condition is not affecting children of younger age? I think we have already dealt with that. Abhishek has asked, Dr. Abhishek Prodhar from Apollo, do these PIMS patients have any flu-like symptoms prior to the onset of this Kawasaki-like symptoms? If yes, by how many days? Abhishek, in the 2 patients that we have encountered, no, we have not encountered any flu-like symptoms. The child that I first described, this 8-year-old girl, she presented with fever, vomiting, and loose motion. She went on to develop the rashes on the 2nd day of fever. And sick children with SaO2 less than 94% shock, moderately sick, PCR positive should need remdesivir. So this is a statement from Dr. Kaul. Dr. Kaul has said that when you should administer remdesivir, so he says that sick children with SpO2 less than 94% in shock, moderately sick, and PCR positive. So these are the indications of remdesivir according. So that is what he states. Then Anjali Dasgupta has asked, in the second case of panel discussion, methylprednisolone was started along with IVIG. COVID antibody test was negative. Could IVIG be started alone? Yes, sir, definitely you can give IVIG alone, as in the first case. But it was the clinician's decision. I think the intensivist, since he was giving not the 2 grams per kg, he was giving 1 gram per kg. He decided to give methylpred along with the IVIG.
So in addition to this, I want to add one point.
Yes.
In a recent recommendation from CDC and the Royal College of Pediatrics and Childhood, they have also added pulse methylprednisolone along with IVIG in patients with high risk factors like infants, carry shock syndrome, CRP more than 130, and coronary J score more than 2, and presence of aneurysm and ASEAN rates. Here they have added pulse methylprednisolone.
The shared trial, isn't it?
Yeah.
Trial.
Yes.
The shared trial.
Dr. Vishwajit Pratap has asked, so what is refractory KD and its management? So Dhrubajyoti, yes, go ahead.
So after giving IVIG, if there is persistent or recrudescence of fever within 36 hours of completion of IVIG infusion, and that can occur within 7 days after that, this is called resistant KD, IVIG resistant KD. So here we have several treatment options nowadays. We can give either second dose of IVIG, or we can give infliximab, we can give steroids, several options. But as Priyankar sir has told, we are also using infliximab in this type of cases for last 3 years.
Yes. So I think I think in fact PGI Chandigarh is also using infliximab. I think, isn't it, Dhrubajyoti?
Yes. We have first reported that one.
Yeah. So I think that was the first published paper that we have a new kid on the block. So infliximab paper.
Yes. New kid.
We have a new kid on the block, and in fact at our center we have almost used infliximab in 30 patients, and they have all responded very well. Keeping our fingers crossed, majority of them, they became afebrile within 24 hours of initiation of infliximab. By 48 hours, the CRPs came down.
So that was dramatic change in the clinical picture, including reduction of coronary artery size. That I can, And we have used 11 cases till now, and all have good response. One giant coronary aneurysm has reduction in the size. That was very promising. But I don't know why this, after lockdown, we are getting very less cases. Last year, during March to July, there are almost 25 cases we had diagnosed with KD. But here now we are getting 3 cases of it during this last 4 months.
No, we have at least 12 to 13 patients of KD since March. So in our center, KD, all these patients, RT-PCR was done, RT-PCR was negative. They were classical Kawasaki disease. So we had at least 12 to 13 patients. And regarding your experience with infliximab and the reduction of aneurysm, in fact, we also have similar experience. We had a baby, 6 weeks old baby, who had presented with fever following the 6 weeks DPT vaccination. And the child went into shock, was being treated as a septic shock, but the fever was not subsiding. The child came out of the ventilator, but the fever continued with raised inflammatory parameters. And then that was the reason that I got involved actually. And then what was very striking was the platelet count. This baby always had a thrombocytosis. So if you are suspecting a baby in shock, thrombocytosis is usually never a feature. So it's usually the platelets are low or normal. if you look at a baby with shock and thrombocytosis, they definitely please think of Kawasaki. And the baby had giant aneurysms on echocardiography. And we give infliximab. The parents were a little hesitant, but still we went ahead. And at 6 months, all the aneurysms have regressed. They've become normal coronaries. And it was unbelievable, but yes, definitely. And in a lot of patients also, we have seen the coronaries really regressing. And anyone would like to add anything else?
Priyankar, are you using infliximab as a first-line therapy?
No, never. We always, it's an add-on drug. Always post-IVIG. Never as first-line therapy.
I think, Priyankar, there was one case from PGI where they used infliximab upfront.
Yes, I know. I think, but that was because of some economic
affordability issue. Yes.
Because infliximab, that 5 grams, 5 mg per kg infliximab dose. So if you give the equivalent amount of IVIG was becoming a little more expensive.
Yes, absolutely.
So they have one experience.
Yes.
But usually the recommendation is post IVIG. Dr. Pulok has asked, what's the mean interval between suspected COVID infection and the development of PIMS? Suparna, I think you can answer that.
Yes, so what the other countries noticed was that after 4 to 6 weeks of the peak in that country, the PIMS actually was being noticed in children. Maybe that time was taken for the children to develop the immune response, I think. So all the children there, like in UK, Italy, they first peaked, and then after they saw the cases with the adults peaking, after 4 to 6 weeks later on, the symptoms started developing in children. Maybe because of the immune mechanism that took time to develop.
Yes. And Pulok has also asked another question. How much does tocilizumab cost? So tocilizumab, if considering the present scenario, it's 8 mg per kg that you're giving. I think tocilizumab comes in vials of 6. It's vials of 80 and 200. Yes, so 80 and 200 mg vials are available. Of course, they have launched the subcutaneous tocilizumab presently, but that's not what you are concerned about. I think you are more concerned about the IV tocilizumab, which comes in vials of 60 and 200 mg. And remember, the vials should be costing, the 80 mg cost usually around 10,000 as far as I remember.
16,000 is the 200 mg, isn't it, Priyankar?
Yes, something like that. It's around 10,000 and 16,000.
Can I add, sir?
Yes, sir. Yes, sir, please.
I think it is easy to remember 80 mg, 200 mg and 400 mg, and roughly it would be 6 to 8,000 for 80 mg and around 12,000 to 14,000 for the 200 mg and around 30,000 for the 400 mg.
Thank you, Sagar.
Thank you, sir.
Sanjay Shahu has asked, are Asian children more susceptible for hyperinflammatory syndrome like KD?
No, this was the contrast. Like PIMS was being more seen in the Africans, Afro-Caribbeans, and the Hispanics. Unlike the KD is more seen in East Asian ancestry children. This was a stark contrast with the KD. I don't know why. Maybe because of ethnicity, genetics, I cannot explain.
So all these are, I think, some genetic factors ultimately involved. in fact, Kawasaki is also possibly having some genetic basis.
Yes.
So Dr. Hemant Kumar has asked, what's the role of COVID antibody test in acute stage? Shupon, you take it up.
Acute stage, like if you do the antibody testing within the first week, the result will be 30% positive. Ideally, it should be done from the second week. Second week, the result comes about 70%, and then till third week is the maximum. Beyond that, I don't know. But before 7 days, it is not advisable to do an antibody. You should better go for an RT-PCR. This is the same thing with every viral infection. The antibody actually takes 7 to 10 days for time to appear.
So even if you are antibody negative, you can repeat the test after a month.
Yes, you should.
You should repeat the test after a month. Okay, Dr. Mihish Sharkar has asked, Mihir is the intensivist,
Yes, yes.
intensivist.
Yes.
So, giving IVIG and steroid in patients with less severe spectrum of disease can lead to immune paralysis and secondary infection. So, I think he has made a comment. Any one of the panelists would like to take it up?
Mihir, what do you want to say? Like in the acute stage, when the child is coming to you with severe inflammation, you have to start some immune modulator. And I think IVIG would be the initiator, followed by steroid if it doesn't respond. First, you've got to save the child, then we think of secondary infections.
And IVIG always remains a safe alternative.
Yes.
If it is affordable, it's very safe.
Mihir, are you there? You can unmute yourself if you want to add some comments.
Yeah, just I want to ask if the patient have just borderline coronary artery dilatation and inflammatory markers is raised, but the myocardial function is reasonably good, around 50%, 40%, and just borderline coronary artery dilatation. Should we go for IVIG steroid upfront, or just wait for wait the patient for next 24 hours? If the patient is going to deterioration, then go for the steroid and IVIG. That's my question.
Mihir, not upfront. We are giving IVIG first. We are trying with IVIG first, and if there is no response, then we go on to give steroids. But I think in such a scenario with the LVF round about 40 to 50%, and you having features of developing shock, impending myocarditis, I would definitely like to treat the patient.
Patient is not in shock. Patient is a lower spectrum of disorder, not so severe. Patient has just myocardial function is just borderline, just 40 to 50% ejection fraction, borderline dilatation of the coronary arteries, and CRP is raised. But patient fever is there, but patient is not hemodynamically unstable. In this group of patient, should we go for this IVIG steroid?
So I would definitely start with IVIG. Right? Priyankar, do you have any comments?
Definitely, if you think your diagnosis is PIMS, because this is a hyper-inflammatory syndrome, you need something to bring down the inflammation. And definitely IVIG should be the first choice, plus minus steroids. Definitely, you can add steroids, you may not add steroids. Like the patient that we first described, we gave just IVIG. We waited for the child. We thought that we'll administer steroids if the child is not improving. Sagar, would you have some comment? Dr. Sagar Bhatta?
Sagar, please unmute yourself.
Yes. I would absolutely agree. There is, according to me, there is no debate on IVIG, because, as you said, even sometimes in septicemia we end up using it. So even if there is a doubt in the diagnosis, there is no denial on the role of IVIG. And I would also say, if we are convinced that there is myocarditis, we will also keep a very low threshold of adding steroids in that setting.
Thank you, sir. Thank you. Dr. Somnath, hello. Hello.
Yes, we can hear you.
Yeah.
Yes, sir.
Somnath has asked something, I think. Just a minute. A congenital immunodeficiency, any form, can they present with KD, or some form are resistant to any experience of KD in immune response? I think Sagar is the best person to take up this. So, Sagar, again, I would like to tell you
what I can tell you is, we have seen patients of Kawasaki disease in patients with X-linked agammaglobulinemia. So it's a disease where B cells are completely absent. There are no immunoglobulins, and these patients have developed Kawasaki disease. So we can probably hypothesize that B cells are not the primary drivers, and it is probably a T cell mediated disease, or it is an innate immune response that is responsible for Kawasaki. So yes, patients with XLA have developed Kawasaki disease, but I don't see any immunodeficiency that predisposes to Kawasaki disease. Hope I am clear.
Thank you. I don't think we have any more questions. I think just a minute. Dr. Hemant Kumar has asked 2 more questions. To recommend IVIG justified in COVID? I think per se it is not given in COVID patients, as far as I know. But if you definitely think of the PIMS, it is the first line of treatment, IVIG, in patients with the COVID-associated hyperinflammatory syndrome. And Dr. Hemant has also asked, I think, is it a statement I think he has made, that IVIG in COVID to be tried in all cases severely symptomatic. Dr. Hemant, I think he is from Patna, so I think maybe they will be trying, that is what he's trying to say, that he will be trying IVIG in all severely symptomatic patients with COVID. So definitely COVID, I think it's an open choice. I think no one really knows exactly how you really treat the patients. So everything has been tried, from antivirals, anti-inflammatory, tocilizumab. So definitely IVIG may be a treatment option. Any of the panelists, would you like to make some final comment?
Go ahead, Priyankar, go ahead.
So I think we had a wonderful evening. We had an elaborate description, and with Dr. Snehal also joining from Mumbai, who has a huge experience with these patients. So definitely everyone throughout India are facing these patients, are diagnosing these patients. It is an entity that possibly we'll be seeing much more in the coming months. So it is very important that to keep your mind open, keep your eyes open. These are the children who will require your correct diagnosis and correct management. The right time you give the IVIG plus minus the steroids, that may save a lot of lives. And maybe these children may not go into refractory shock and the ventilators. So thank you on behalf of the panelists I thank the organizers for organizing this wonderful CME and a pan-Indian presence I think we had in this evening.
Yes.
Thank you everyone.
Thank you, Dr.
Thank you, PlasmaGen. Thank you, PlasmaGen, for the wonderful opportunity you gave us to share.
Thank you, ma'am.
Thank you very much. Thank you.
Thank you, ma'am. Very good evening, one and all in the audience. On behalf of the entire PlasmaGen BioSciences family, including our IVIG range of Plasma Globe, 0.5 gram, 2.5 gram, 5 gram, and 10 gram, I cordially thank you all to have come and spent your Sunday evening with us and sort of joined in this simply electrifying session, buzzing with case experiences. PlasmaGen BioSciences is proud to have put together this webinar under the kind and patient guidance of Dr. Priyankar Paul, and who successfully drove this along with Dr. Amitava, Dr. Suparna, and Dr. Sharma. Through this webinar on Kawasaki disease, we have taken our awareness creation efforts digital, and we want to thank all the doctors who've taken time to add more clarity towards this entire curiosity around Kawasaki and COVID-19 situation in these current times. For those who joined in late into the session or might have missed out a few crucial minutes, please be assured we'll be sharing the link to the session at the earliest with all of you all via an email. We also request attendees, based on the questions, I'm positive, we would like to hear some positive feedback from you all as well. So we all request all attendees to share your feedback on the webinar through the feedback button you can see on your screen at the bottom. And lastly, we do have your contact details, and we eagerly look forward to connecting with you soon with some of our future sessions around any of the immunodeficiency disorders affecting children. Thank you once again. Good night from all of us at PlasmaGen BioSciences. And final thank you, Dr. Priyankar Paul, Dr. Amitava, Dr. Suparna ma'am, and Dr. Dhrubajyoti Sharma. And I also thank Dr. Sagar Bhattar and Dr. Snehal Kulkarni ma'am to have joined in from Mumbai and on a very last minute request and sharing your vast experiences from Mumbai. Thank you, ma'am.
Thank you very much.